Hey guys, and welcome to you a little bit in a clinical probe designated to non-small cell lung cancer targeted therapies. My name is Nathan J. Matlock, and I am the PGY2 Oncology Pharmacy Resident at Monument Health. So I think to get our conversation started, we need to really talk about what tyrosine kinase function is. So kinase is an enzyme that catalyzes the transfer of phosphate groups, so E, which has 3 phosphates, and a kinase is going to rip one of those phosphate groups away. So TKIs for the treatment of non-small cell lung cancer target mostly receptor tyrosine kinases, or RTKs. These are transmembrane composed of tyrosine amino acids on the intracellular side of the cell membrane and a signal binding site on the extracellular side of the cell membrane. Once a ligand binds to a single polypeptide ligand binding site, it will then dimerize with another receptor-bound single polypeptide. Once the 2 single polypeptides dimerize, the intracellular tyrosine amino acids are activated. The tyrosine amino acid will phosphorylate the tyrosine on the opposite polypeptide until all sites are phosphorylated. Once the dimer is phosphorylated and active, a relay protein will come in and attach to a phosphate group that is bound to the tyrosine kinase, and the conformation of that relay protein will then result in a cascade of signaling. So kinase inhibitors will bind to this tyrosine domain phosphorylation, thus terminating signal propagation. So KRAS is our first tyrosine kinase inhibitor or target. In mutated cells, the KRAS GDP is upregulated beyond a normal signaling pathway, and the KRAS inhibitor binds to phosphorylates KRAS GDP to KRAS GTP, which prevents the cellular transcription protein synthesis. Our next one is EGFR, which is a mutation-positive non-small cell lung cancer, so H1B to 3A. So in this, osimertinib is the main agent that we kind of go with for a NCCN 2A recommendation, particularly patients who have the T790M mutation domain. So osimertinib is considered again with patients with completely resected early-stage disease, previous adjuvant chemotherapy, or who are ineligible for platinum-based. Typically with the EGFR, we see more males than females, more Asians, light or never smokers, and 10 to 15% of non-small cell lung cancers. And talking about the exon mutations, exon 19 and 20, specifically 20 having that T790M, and that propagates resistance to erlotinib, gefitinib, and afatinib. And that's a current rate of about 60% if they have that mutation. So we want to diagnostic biopsy or resection in stage 2B, or if they're a high risk 1B or 2A, and if they have metastatic non-squamous non-small cell lung cancer. And our agents, most commonly seen osimertinib, erlotinib, gefitinib, and then of course domitinib and mobocertinib. For our ALK inhibitors, they are thinking adenocarcinoma. These are going to be non-to typically younger in age at diagnosis, current 4 to 8%. And what happens here is you have an endosome 2 that links the 5' end of the MLA4 gene, 3' end of the ALK gene. You're going to test individuals if they're metastatic non-squamous non-small cell lung cancer. And our agents typically seen in these agents is the alectinib, ceritinib, brigatinib, crizotinib, and lorlatinib. Next up is the ROS1 mutation or receptor. This is, you're thinking adenocarcinoma, again, no smoking history. Here our occurrence rate drops to about 1 to 2%. And with this, you're going to have a rearrangement occur, which causes a fusion of ROS1, and it's going to basically activate the TK domain and propagate that signaling cascade. We want to make sure we test prior to first line in metastatic non-small cell lung cancer. And typical agents we're going to see hitting ROS1 are going to be crizotinib and toripalimab. Next is in the pathway that you can see is BRAF V600E. It's the most common BRAF mutation, typically about our non-small cell lung cancers. Occurrence rate is about 1 to 2 individuals. This does not usually overlap with your EGFR ALK rearrangements. And we're going to make sure we test in non-small cell lung cancer, so not this cancer. And then agents we're going to see BRAFINIB plus minus trametinib or BRAFINIB. So interesting note, trametinib is actually a measure. You can see it in the pathway down there, which is a kinase after the BRAF kinase. So a single agent MEK inhibitor will actually increase the amount of SOS1, which is going to cause the K amplify its production, and I guess it's phosphorylate, pushing the cascade and oversaturating. So we want in our BRAF V600E mutations in BRAFINIB, go ahead and pair it with trametinib, cut off both pathways, so that way we're not overstimulating, but then allowing that MEK to phosphorylate the KRAS. NTRK fusions, these can have a numerous fusions occur. No specific clinicopathogenic features are really available. And then we're going to test in metastatic disease in those non-small cell lung cancer patients considered in small cell lung. Agents we're going to see lorlatinib and then entrectinib. So just about our NTRK, these can result in a break between the extracellular receptor and the intracellular and kinase regions. The intracellular tyrosine kinases are still able to dimerize and phosphorylate each other, resulting in a proper signaling cascade. The NTRK or inhibitor will bind to these tyrosine portions and block the phosphokinase region, thus shutting down signaling propagation. For our MET receptors, in older women that were non-smokers, they do have a mutation at exon 14, and it can result in a broad range of alterations. We want to make sure we're testing in an advanced metastatic cell lung cancer. In our typical agents, capmatinib, crizotinib, and tepotinib. And then that brings us to RET. We are thinking adenocarcinoma, and this occurs in smokers and non-smokers. And our occurrence, you can see, is about 1 non-small cell lung cancers. And we want to make sure, again, we testing for these mutations in advanced or metastatic lung cancer. And then our agents, selpercatinib, valsartanib, and cabozantinib will typically be. So targeted therapy, first-line treatment for metastatic or stage 4 patients who have targetable mutations. So if no targetable or no actionable mutation is found, then we want to evaluate the PDL status for single agent or combination immunotherapy. If non-squamous molecular test EGFR or ALK is recommended, we want to make sure we recommend for additional testing. So here, this chart I have on here on the far left side, you can see mutation. Typical agents we will see utilized, daily starting doses, and then the NCCN recommendation. And I've also included the chart that you had seen going through the presentation, showing the receptors and kind of where they target. For example, if we look at the EGFR on the far left, the little group, you can see by targeting those interesting kinase regions, we can actually stop signaling cascade through pathway A, which is that JAK, B, which is your typical MAPK and then as well as coming over here to the PIK3 pathway. And then open up for questions. If anyone does have any questions, you can reach me out in matlock@monument.health. I will respond to you as quickly as possible. I enjoyed getting the presentation. It helped reinforce a lot of good ideas about these actions that can be often overlooked. So I appreciate it, and thank you.